Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article, and in this case, number 19 and number 20. Welcome to the Pain is Not the Only Problem podcast. Article 19, Pain is Not the Only Problem. Spinal Stability, Part 2, followed by Spinal Stability, Part 3. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. Various definitions of the term spinal instability have been published, and the definition varies among experts since some are clinicians, others radiologists, and others bioengineers, according to Bergstaller 2015. Spinal stability and instability can be described in a variety of ways. Let's look at a few of these. According to White and Punjabi, it can be described as the loss of the spine's ability to maintain its pattern of displacement under physiological loads. So there is no initial or additional neurological deficit, no major deformity, and no incapacitating pain. According to Sonntag and Marciano, increased angularity or translatory motion noted on flexion extension lateral of antero-posterior bending radiographs that exceed 4 millimeters or 10 degrees. That seems pretty complicated. Let's look at what Freumeyer says. Freumeyer offers us this. Segment instability is defined as a loss of spinal motion segment stiffness, such that the force application to that motion segment produces greater displacement than would be seen in normal posture. Pitkänen offers us this. Poor correlation between radiographical abnormalities in functional radiographs and clinical signs suggests lumbar instability. So you can see that it depends on the perspective of these different authors and their specialties and how they define or assess or appraise spinal stability and instability. It appears that spinal stability has unstable definitions. However, it is prudent and essential to agree on the role of spinal stability and agree on the spinal stability contributors. This way, spinal stability can be understood, evaluated, diagnosed, and corrected across disciplines. In nearly all low back pain cases, the clinician can find 1. Insufficiencies in patient ADLs or work or recreational habits, practices and biases related to their low back pain complaint. 2, lack of access to spinal stability related exercises that include varied planes of motion, strengthening, and again, work and recreational specific exercises. And then finally 3, a fully managed care plan to implement stabilizing routines, including patient education. Foremost, spinal stability requires motor activation around the spinal column or through the trunk, while the spine is aligned axially with natural gravity and must be synchronized with the adjacent motor groups that stabilize the pelvis, knees, and ankles, even with overhead activities. These motor activations must be synchronized with core recruitment and horizon line gazing. These motor activations must be of sufficient strength and coordination to accelerate and decelerate the trunk, deliver and accept loads, delay fatigue, maintain neutrals, that's plural, neutrals, form, and deliver useful and safe function. Neutrals implies that regardless of the position of the spine, there is a best case neutrality that can be commanded to stabilize the spine regardless of the position of the spine or the activity. Spinal stability in no way implies stiffness nor rigidity. Secondly, spinal stability must be understood by the clinician in order to evaluate, diagnose, and correct spinal stability insufficiencies. It is a mistake to diagnose and treat low back pain without addressing the importance of the spine's reliance on pelvic features. The pelvis is the foundation of the spine because it provides it with a locking mechanism. The sacrum is essentially encased between the broad ilia. However, the pelvis itself does not have a home position. It is essentially floating at the acetabulum between the femurs. There are 16 muscles attached between the spine and the pelvis, and 48 muscles attached between the legs and the pelvis. Therefore, 3 times more work is being done to stabilize the pelvis than to stabilize the spine. If the pelvis is not stable, what are the chances that the spine is going to be stable? Why aren't low back pain clinicians talking about pelvic stability? Why are low back pain patients being treated for symptoms without evaluating spinal and pelvic stability together? According to Roberts' 2016, spinal stability and therefore hip stability and its relationship to center of gravity relies on a stiffness or percentage of thoracolumbar and sacrotuberous and rectus and pelvic floor tension. Seems logical. Thirdly, since spinal stability is not acquired but learned, the patient is fully accountable for the outcomes of any spinal stability program. The patient should be able to explain basic spinal anatomy and the usefulness of their program and express positive perceptions within the program. The patient should demonstrate confidence and compliance. According to Reeves et al. 2017, the spine is either stable or it is not. There is no index. It is a dynamic, multi-joint complex, able to perform its functions, bear loads, allow movement, reset to neutral, absorb shock, limit range of motion, and control variability, and cope with uncertainties and disturbance, approximate stability, eliminate delays, and once stability is established, shift to performance with fatigue resistance. It's a great definition. The surgical model shows us that the tendons of the lumbar paraspinal muscles are among the thinnest tendons in the body, suggesting that these tendons are an unsuitable size to transmit force to the bone. Contraction of the lumbar paraspinal muscles does not act to pull on effector tendons, but mainly to increase stiffness, to provide spine stabilization, known as the bone muscle composite beam, and to store elastic postural energy. This is offered to us by Kreis et al. 2019. Oakley et al. 2005 offers us this from the radiographic perspective. Any radiation must be compared to the benefits of useful information gained. Radiographic drawings such as Harris and Reiser-Ferguson models do not offer us an observable coupled motion of the spine related to VAS plus range of motion plus quality of life. If the goal is pain-free function, radiographic evaluation fails to provide evidence. Goldby et al. 2016 offers us this. It is not uncommon for physiotherapists to make a diagnosis of clinical instability in the absence of radiographic instability. The inability to perform a co-contraction of the deep local muscle system has been cited as the diagnostic indicator of spinal stability, the abdominal hollowing maneuver. What is surprising is how well the spinal stabilization program simultaneously controlled pain. Understanding low back pain requires taking another look at the importance of synchronizing hip stability and core activation. Understanding the low back pain patient requires taking another look at patient education and participation, since pain is not the only problem. Article 20, pain is not the only problem. Spinal stability, Part 3. Appraising quality of life should be evaluated when case managing the low back pain patient. Oral and injectable medications are commonly prescribed by the medical doctor for pain, inflammation, or muscle spasm. When medications become the first line or gold standard in low back pain case management, contributors such as lifestyle, work and recreation activities, patient expectations, and underlying faulty movement patterns are never evaluated or considered. Medications have side effects, including addiction. Medicating does not involve patient education regarding their underlying problem. It only addresses symptoms. Medications can't correct spinal stability. Surgical consulting as a first line of low back pain case management attempts to correct a picture of a spine, and what we mean by a picture is advanced imaging or plain films, and not the function of the spine. Protecting the patient's quality of life standards should insist on employing a rigorous conservative care approach, specifically to establish spinal stability. Surgery causes permanent reconfiguration of tissues into scars that cause further complications, since scar can't contribute to the physio-chemo sense signaling required to activate spinal stability. And what we mean by this is that scarred tissue can't provide proprioceptive feedback about joint position, muscle stretch, tension, and length. According to Punjabi 2006, the spinal column has two functions, structural and as a transducer. Transducer signals generated by mechanoreceptors are corrupted. The muscle response pattern is corrupted, producing high stresses and strains leading to inflammation, inflammatory tissue, and have abundant supply of nociceptive sensors and neural structures. According to Chatterjee 2018, scar has no mechanoreceptors. Somatosensing as well as mechanotransduction is the conversion of mechanical forces into biological signals, a process that reveals environmental features to the organism. Dysregulation leads to peripheral neuropathies. Arnall et al. 2012 offers us this. Sodium current reduction, along with increased fibrosis and impaired intercellular coupling, could lead to a marked decrease in conduction velocity. Due to scarring and excision of spinal structures, surgery may complicate attempts to recorrect spinal stability. Since surgery does not contribute to motor mapping, it can't correct spinal stability. Physical therapists are prescribed by medical doctors in an attempt to provide palliative and conservative care. Physical therapists use massage, temperature, and plug-in modalities such as interferential, ultrasound, infrared, etc., and pre-formatted exercises from charts and handouts. While temporary quality of life may be addressed with palliative care offered by the physical therapist, the therapy can be inconsistent, nonspecific, ineffective, inaccessible, and in large part passive. Passive exercises do not command much of the patient's experience to establish spinal stability if the patient is laying on the floor doing a dead bug. Most, if not all, physical therapy exercises are absent of spinal acceleration into deceleration, producing and accepting spinal loads. Many spinal neutrals mimicking real-life near-injury drills that require quick learning, instant judgment, fast reaction, sequencing, and synchronization of the hips and core. Physical therapy routines are performed in isolation because the prescription identifies an area of the body to be treated instead of the whole patient approach. PT is performed until the patient's pain is resolved or reduced, but spinal stability is not addressed or corrected. Manipulative therapy, such as in chiropractic manipulative therapy, involves manipulation of the spine at a segment or joint that is identified as subluxed. This is the classic bone out of place chiropractic reductionist theory explaining low back pain. The low back pain patient's quality of life can be reduced if the patient is required to attend many appointments over a long period of time with only promises of getting better. Globe et al. 2015 offers us this. It is rare that a patient would require 4 visits per month to manage advanced or complicated low back pain. It is not in the patient's best interest for the chiropractic doctor to use the least evidence-informed chiropractic techniques as their first-line approach. Manipulative therapy, as in medical care and physical therapy, does not address identifying, evaluating, diagnosing, and correcting spinal stability. The gold standard for case managing the low back pain patient would be to employ the whole patient approach, since it addresses the underlying mechanisms and contributors of spinal stability, patient values, and patient expectations. The whole patient approach does not fit into the box of medical practices or beliefs. This means any physician or clinician can employ it. It does not belong to one discipline. The whole patient approach combines science with an equitable perspective that reimagines better patient outcomes. The whole patient approach involves a brief consultation with the patient to explain the value of movement and spinal stability in their course of care that can begin the same day. The clinician's failure to identify and treat spinal stability can cause a poor quality of life experience for the patient. Patients commonly do not want delays in diagnosis, delays in care, endless referral appointments, and these days are increasingly concerned about pain drug addiction and side effects. The clinician can reframe their care to offer better patient outcomes by improving patient quality of life instead of focusing on pain, since pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.